Hello everyone, this is Ndashime Jean Batista, and in this video I'm going to be presenting about urological investigation. So the first urological investigation is to assess kidney function depending on the presentation of the patient. But the way we measure kidney function is through glomerular filtration rate. The property of substance that can be used to measure the glomerular filtration rate are the following. First of all, that substance has to be not secreted, and that substance not reabsorbed. So those are two properties of substance that we need when we were considering the substance, ideal substance that could help us to determine glomerular filtration rate. So the example of that substance, it is urine, but this urine is for experiment. So as we need to measure, glomerular filtration of the patient, creatinine is going to be helpful due to the fact that creatinine is not reabsorbed at the level of so as it doesn't get reabsorbed, we can use it as way of calculating or measuring glomerular filtration rate, but it can overestimate because part of it is secreted at the level of proximal converted tube. So even though it is helpful to measure glomerular filtration rate or assessing kidney function, but it may overestimate glomerular filtration rate. So we use it, but we know that it can overestimate. So the way we calculate glomerular filtration rate, it is indicated in this formula. So we take the volume of urine, which is urine output for maybe 24 hours. Then for those 24 hours, we multiply the amount of creatinine in the urine that we have corrected over plasma concentration of creatinine that has been measured. So using this formula, you will find normal glomerular filtration rate, it is above 100 milliliter per minute. So this is how we calculate, and we found glomerular filtration rate of clear. So let's move on another part of urinary examination. So why do we need to do urinary examination? We need to do urinary examination because maybe urine may be containing blood, which may be visible or non-visible. Also, it may be containing proteinuria. So some patients may have hematuria associated with proteinuria. Other patients may be having hematuria not associated with proteinuria. So you need to investigate those pathological causes, which may be different. Uh, in urinary examination, we will be looking for nitrates that are produced by bacteria and someone that we suspect UTI. We can find white blood cell in urine. So all of those factors that we may find on during urine examination, they are also used in urological investigation, so that to rule out some causes of urological complaint. So urine microscopy. So we do urine microscopy to see some cells which may be in the urine, to see cast, to see crystals. So during urine microscopy, we can see morphology of red blood cells. Take an example. Red blood cells, which are in the urine, because they come from maybe at the level of ureter or urethra, they will be having different morphology of the red blood cell, which has been folded because it has been trying to pass through at the level of podocyte, at the level of basement membrane when during filtration process. So for the patient having hematuria because of glomerulonephritis, we will receive modified or abnormal shape of red blood cell. But for someone with stones which are causing irritation on urethra, we'll be finding normal red blood cells. So casts, what are casts? Actually, casts, the cast, it's just that first of all we have a type of mycoprotein which surrounds the urinary tract. Those protein may come just out during urination, having or containing nothing inside them. But when those mycoprotein, it is when mycoprotein plus maybe white blood cell or red blood cell, we say that this is cast. So for cast to be formed, or to have that mycoprotein which combine together with this white blood cell or red blood cell, it has to be something which happened at the level of hidden, because these mycoprotein are found in renal tubers. So as there is white blood cell or red blood cell which are going through renal tubers, which may be proximal convoluted tubules, distal convoluted tubules, or loop of Henry, and they meet with this mycoprotein, they are the one which are going to form cast, which will appear on microscope. But for crystals, it's just maybe stones or other causes of crystals, mostly stones. This is what we find on urine microscopy during examination. So what is urine cytology? Urine cytology, it is started for the purpose of studying the cells morphology, because when in a patient have a tumor, there is morphology, there is a change in the way nucleus look like, there is a change in way cytoplasm, change in nuclear cytoplasmic ratios. All these are what being studied in urine cytology. So also in the urine cytology, they look for PSA, prostatic specific antigen, which is a type of enzymes that produced by prostate gland. So they look for its amount or its quantity so that they could differentiate if it is malignant, if it is benign, or it's a normal, just a normal case, or prostatitis condition, which also may lead to increase in PSA. So other urological investigation, they are radiological imaging. Radiological imaging, we may do ultrasound depending on the finding or the reason that may lead us to do that ultrasound, or we may do KUB, which is kidney, ureter, and bladder X-ray. This is going to be helping us because there are some stones which are radiopath. Those are going to be seen on this KUB, but there are also some which are radiolucent, so those are not going to be detected on KUB. So we can do intravenous urography for different reasons, maybe for looking for some strictures, for looking for pathological condition the kidney. We, as we be going through different PowerPoint presentation, we'll be finding the reason why someone can be we can a surgeon or urologist can request for intravenous urography of the patient, because there are various reasons that you need to be evaluated, because you inject the dye in the patient vein, then as the dye gets filtrated at the level of glomerulus, you'll be taking pictures to be analyzed. So there is other urological contrast study. The one is video cystourography. So this video cystourography is used to investigate maybe the patient might be having vesical urethral reflex. So this video cystourography, you look for filling and emptying of the bladder. So as you fill or you push dye into urinary bladder, you may look how far the dye can move up if someone has vesical urethral reflex. Other investigation which can be done is cystography. This is also retrograde filling of the bladder via catheter with contrast, and identify vesicocolic or vesical vagina fistula, because they are in close relationship with each other at the level of pelvis. So you can also investigate for blood rupture, which can be intraperitoneal or extraperitoneal. Urethrography, this is when you want to study for ureter, structure of the ureter, because this is either going to show some ureterous strictures or some site of injury when you are using it for the patient who has pelvic fractures. So there is other known as urea reprogram. This is a procedure done also to look for reflux, but these reflux have some implication different from reflex that we have been studying, maybe using in video cystourography, because this is the patient who have underwent surgery, maybe of removing transition cell carcinoma of urinary bladder. As urinary bladder gets removed, surgeon may do anastomosis of ileum with ureter, and then there is stoma outside, which is going to be where urine will be coming out of this part. So during this procedure, they did what is known as urea conduit. This is what is urea conduit. It's just part of intestine, small intestine area that has been connected to ureter. As we do this examination, we just want to look if we inject the dye, there will be dye which moves up in the ureter. If it moves up, it just tells us that there is no obstruction to the connection that you have created. But if the dye could not move up, this is a problem. This is where they say that absence of this reflex indicate the obstruction of the ureteral area junction, which may result from ischemia or recurrent transitional cell carcinoma in the ureters or renal pelvis. So the other investigation is retrograde urography, as the same things. It's just the camera of fiber optic cystoscopy that they insert through the urethra and urinary bladder, and you go to the level of ureter. So it's a retrograde installation of contrast into the ureter by ureteric catheter inserted into ureter via cystoscopy, which may be rigid or flexible. Provide the excellent visualization or definition of ureter and renal pelvis, maybe to detect transitional cell carcinoma or radiolucent stone in a patient with persistent hematuria, where other tests have shown no abnormality, no signs of UTI. So it's just patient comes with hematuria and it has persisted for that long, and it prompts us to do further investigation. So this is done under general anesthesia. The other technique is computed tomography or CT scan. So CT scan and magnetic resonance can also be used during investigation in urological department. So CT scan can be with contrast or without contrast for different reasons. It can be without contrast when you look for calcification of auriculi, or with contrast when you look for the source of hematuria, soft tissue, or tumors. Off notes: hematuria. During hematuria investigation of the site and the cause of urinary tract bleeding. This is where we need CT scan, and the CT scan has did a lot job. We just have the replaced intravenous uretrography, renal ultrasound, flexible cystoscopy, and urine cytology, due to the fact that it's do the same job at one time. So there is what is known as multi-detector CT urography, which has high sensitivity and specificity, but the problem comes to the cost and radiation. So it is recommended in macroscopy hematuria of the patient with age above 40, history of smoking, occupational exposure to benzene and aromatic amines. So as you can see, it's the patient who are more likely to have hematuria that we suspect may be caused by tumor that is going on in the urinary tract. So it helps us for cancer detection and staging, but above all, MRI it's a good test than this CT. So there is other test known as uroflowmetry. Uroflowmetry helps us first of all to detect volume of urine voided, contractility of the patient bladder, and conductivity or resistance of the urine, because the patient urinate on that machine, and the machine can detect that the urine, volume of the urine eliminated, and contractility, the maximum power of contractility and conductivity resistance of the urethra. So, but because these tests have not shown, because someone with obstruction and someone without obstruction, it may vary in those patients, and it doesn't tell us about outcome or changing the intervention. So some urological association recommend it, others say it's an investigation of choice. You can either do it or not, depending on the clinical trials that has been done to the patient with obstruction and the patient without obstruction, and they found that it's just the function of it is limited. So the other exam is post-voidal residual urine volume measurements. So this is done with ultrasound. So this is done maybe in a case we think the patient might be having strictures, a patient who may need transurethral resection of prostate, but also this post-voidal residual urine volume measurement that did not predict the chance of developing urinary irritation and of need for transurethral resection of prostate for worsening lower urinary tract symptoms. So still this exam is not recommended by some urological association, but it can be used to evaluate maybe the patient who might need transurethral resection of prostate, who present with lower urinary tract symptoms. So the last test that done in urological patients, it's a test that measures cystometry, also measure pressure flow study and video cystometry. How this test is done? This test is cystometry. It helps us to measure the pressure that bladder has for its maximum contraction, and also measure the pressure of output that comes because of that maximum level of contraction. And the video cystometry combine all of these. It measures the maximum pressure of bladder to contract, and also measure the pressure of urine that comes out because of level of bladder contraction. So this test is being used for the patient with urinary continence to see if it is overactive urinary bladder that is causing urinary continence. So these are the tests that's done in urological department, but it may be confusing, it may be lacking some clarification, but as we go through PowerPoint, I hope we'll be finding application and the use of them. I thank you everyone, and thank you so much. See you in the video about the class presentation. I hope we'll be finding the implication and the use of this introduction about urological cases. Thank you so much.